Hi, welcome back to the Above and Beyond series of lectures where we get a chance to give the time and energy to some of the medical emergencies and traumatic injuries that we don't typically get to focus on in a regular EMT or even a paramedic course. Today, we're going to be talking about thoracic aortic aneurysms. They're particularly pernicious and dangerous because they present, as far as signs and symptoms go, very quickly and can kill almost as quickly. And because they're another kind of chest pain, we are often not looking for this. In fact, we're looking for, if you've, well, we'll get into it in just a minute. You can tell your friends and family about this. Anybody who needs CEs, make sure you contact C.A.R.E Medical Education and we can get them all set up for you. In addition, we'll have podcasts that you can listen to for your enjoyment. And if you need any additional hours, you can then sign up at C.A.R.E Medical Education to take the test at the end of each podcast and do an evaluation form. And you get an hour for your enjoyment of listening to me speak. So let's get right down to the nitty gritty, shall we? So as we begin here, again, we will be talking about thoracic aortic aneurysms. They're aneurysms or ballooning that occur specifically in the aorta. I call this lecture Looking for Zebras because if you've not heard the saying in the past, there's an old credo. If you hear hoofbeats, think horses, not zebras, meaning if you hear chest pain, think of the most common reasons we would have chest pain. Think heart attack, right? Don't think thoracic aortic aneurysm because they're rare. But here's the problem. What if it is zebra? What if it is thoracic aortic aneurysm and they're trying to pigeonhole this into heart attack and it's just not showing like that? It's not presenting like that, and it won't, because essentially it's not a cardiovascular or electrical conduction issue. Um, well, it is a cardiovascular, it's the actual blood vessel of the aorta, but it's not having to do anything with the coronary arteries or the conduction systems. So a thoracic aortic aneurysm is an aneurysm or ballooning or weakening. And we need to discuss exactly what it is, where it is, the risk factors for getting aneurysms, the specific signs and symptoms that you would expect to see, some of the unusual signs and symptoms you would um, be thrown off from at first unless you were looking for thoracic aortic aneurysm, and then the treatment for it. So here we have a 56-year-old male complaining of chest pain. He looks very similar to another teacher at City College here. And well, he's clutching his chest. We're very concerned. We show up on an ambulance, and my partner and I begin to assess this patient along with the fire crew. We get a blood pressure of 92/70, a pulse of 130 and regular, respirations at 24, non-labored, but grunting, and skin signs, cool, pale, diaphoretic. Well, okay. In terms of our blood pressure, that's not a good sign. In fact, anytime it's below 100, I know in some textbooks they say below 90 systolic, but 100 is a really easy number to remember. So just I make all my blood pressure stable or unstable, compensated versus decompensated. Let's just keep it at 100, unless we know this patient usually has a lower blood pressure. And so in which case you can ask them, is your blood pressure usually low? And if it's not, then let's be concerned with 92, or let's be concerned even with 98. So this is getting from one, the way I would look at this is there's decompensation occurring. Whatever's going on with this patient, it's not going to last much longer. The regular pulse usually indicates that the heart is regular, no? So I would say if, and not always, and again, I will make some broad generalizations for our cardiac patients, which are not always the case. However, it is important to think about a heartbeat in terms of regular, irregular, and in terms of what the underlying problem is. Typically, if there's an issue with ischemia, there's an irritable focus of the heart, um, it tends to be irregular. There's going to be aberrant beats that are causing irregular rhythms inside the heart, and therefore you're not going to have a regular rhythm. It could be regularly irregular, it could be irregular. However, it would many times be regular. So this concerns me that there's a rapid heartbeat, but it is a strong systematic beat along the way, which kind of indicates maybe it isn't the heart. This might be your first indicator to think, is it the heart that's causing the chest pain, or is it something more nefarious? Respiration's 24, a little elevated, not too elevated, not considering the way that they're breathing. It could be due to pain. And then there's this grunting thing, which is a very unusual sign and symptom. It's kind of a sometimes you get that. Sometimes you get that with respiratory patients like asthmatics or maybe CHF. They're kind of grunting to try and open up the bronchioles. So this is an odd one, and it would depend on what that grunting actually looks like. Is it like clearing the throat? Is it is it a cough? Is it a a pushing of air out at the end? And then, well, skin cold pale, diaphoretic. We know that's just not good skin signs. That's shocky, as we would say. Chest pain begins suddenly while watching TV. Okay, movement causes a provocation of pain. So does coughing, weird. Palpation as well, even weirder. That sounds more musculoskeletal in terms of our chest pain, yes? Because if we are touching and moving the skeletal frame around, that shouldn't change a heart pain. You're not literally touching the heart. There's a rib cage and there's muscles and there's fat and there's everything in front of it. So moving around usually doesn't change someone's chest pain if it's cardiac related. So again, there's another little incongruity that would concern me. Quality of pain is now sharp. Okay. Tearing, no bueno. Pinpoint, okay. That is not what your, again, typical cardiac chest pain is like. We know, again, another generalization, which may not be the case for females, diabetics, previous heart attack patients, but typically cardiac chest pain is diffuse. It's cramping. There's an elephant on my chest. There's someone standing on my chest. It's all around this area. It's not pointing directly to where it is. It's not tearing, certainly not tearing, and certainly not sharp. Sharp's one that might get you thinking along the lines of pulmonary embolism. So is pinpoint. Tearing is exactly what it sounds like. When there is a pain of something tearing, that almost always is a symptom of an aneurysm, of a dissection of an aneurysm. And we'll get into that in just a minute. Radiation of pain is to the high and mid back. Okay, usually those are our areas of referred pain. So that would indicate something more than cardiac in nature. Typically, a cardiac chest pain radiation is to the arm, the left arm, up the jaw, sometimes to the back, but left arm is your traditional radiated pain. And severity 10 out of 10. That could still be cardiac. And it's been going on for 20 minutes. Okay, we go through this. We did our signs and symptoms. Those are our signs and symptoms. Our past medical history is as follows. Allergic to iodine and shellfish. Doesn't really concern us here. Lisinopril, Coreg, naproxen, Vicodin. And those are for hypertension, high cholesterol, Ehlers-Danlos, and myalgia. Okay. So we know hypertension, high cholesterol, those are also really bad cardiovascular illnesses to have for heart attack, but also for other vascular problems. Now, Ehlers-Danlos and myalgia, what are those exactly? And do you know what Ehlers-Danlos is? We're going to get into several different congenital diseases that are they really make it easy to have aneurysms. They're real risk factors, and Ehlers-Danlos is one of them. So if you don't know that, well, okay, if you don't know what Ehlers-Danlos is, how are you going to find out? I would if I were, again, I don't, if you're operating without ego, there's no reason to not ask your crew if they know what Ehlers-Danlos is. I'm on the fire engine, but I could ask the ambulance medic what Ehlers-Danlos is if they know what it is. And if nobody knows, here's a phone. Use your phone, or better yet, if you're doing the lead assessments, have someone else in your crew who's not doing anything. Let's say the captain who's writing. Um, Not to say the captain doesn't do anything, but the captain who's there scribbling down these medical illnesses, diseases, and everything, have him look up Ehlers-Danlos quickly. Have somebody else who's not working on something check it out on their cell phone. One of the few times it makes perfect sense to pull out on a call. And really, the sooner we get to the bottom of this, the better. So Ehlers-Danlos, oftentimes, because it's connective tissue disorder, causes pain throughout the tissues of the body. Hence, the myalgia you might be able to glean is probably related to Ehlers-Danlos, and so is obviously the naproxen and Vicodin for the pain associated with it. They've had black tea and a butter biscuit. Lovely, lovely. And that would be, well, so the tea maybe is a little bit of a stimulant, which caused some vasoconstriction, which maybe prompted this. Who knows? And in terms of the events leading up to this, they were sitting down to watch Game of Thrones, which definitely dates this episode. And they suddenly had immediate 10 out of 10 chest pain. And that immediate 10 out of chest pain is another big indicator, big clue that this very possibly could be an aneurysm of some sort, either a thoracic aneurysm or an aorta or a descending aortic aneurysm, an abdominal aneurysm, et cetera, depending on the location, really. So these are all really bad signs of an aneurysm, or some of those are embedded within that assessment. An aortic aneurysm is a weakening or bulging or ballooning of in this case, the aorta. So it bulges off. It should typically not look like that. It should look nice, symmetrical, uniform diameter, rather than this ballooning that's taking place. And the ballooning that's taking place is a tearing of the tunica, the lining of the artery, of the aortic lining, which we'll get into. So it's categorized by the way that we categorize aortic aneurysms is by the involvement in either the ascending portion or the descending, or a mixture of both. How extensive is this separation, this aneurysm? It can lead, of course, to aortic dissection, and that is a tearing of the lining. And eventually, if not treated, or if there's additional trauma or some other issue that occurs, it can cause aortic rupture. And of course, if aortic rupture occurs, well, the aorta is the largest artery in the body. Blood pumps through your entire system in about a minute. So if you were to tear this in half, you would bleed out your entire blood volume in about a minute. It wouldn't take much longer if you had some perforations here and you bled out. It would take minutes. And this is why mortality rates are so close to 100% if if unassessed or undiagnosed, especially outside of the hospital. So here's what we're looking at here. Here's a good cross section of the aorta here as it's begun to tear. Let me just scoot this out. Here are the different layers of the arteries. Pay close note to the tunica intima, the innermost lining where the blood vessels are flowing through freely, the smooth muscle layer, and this tunica externa, very hard, kind of almost like the dura mater, very kind of leathery but flexible, fibrous outer layer where it's like a pipe, it's like a garden hose where everything's kind of held together. That's somewhat elastic. These arteries can constrict and dilate. But when you have weakened connective tissue, those linings are much more flexible and can, well, react much more to higher pressures, much higher especially these much higher pressures coming off directly off the left ventricle. And when we're dealing with that, the blood is not only coming out at high pressure, but it's immediately angulating and going up around a sharp corner and coming back down. And so, if you're going to have a weakened tissue, you would hope it wouldn't be in this area. You would hope that this would be as reinforced as possible. Unfortunately, you don't get to choose where you have weakened tissue. And if you have congenital diseases, it's going to affect your connective tissue systematically. And so, you're systemically rather. And so, as blood comes off of this and pressurizes this area, eventually ballooning can occur. And as the ballooning occurs, it can then start to tear between those two layers. It can start to force a separation of the layers as it travels through at a high speed, at a high pressure. And so, as that begins to pressurize and separate, you begin to get this dissection, or the layers of the arteries between these two layers begins to separate, dissect, if you will. And as it dissects, remember, it's dissecting in 3 dimensions. Here's that occurring down the descending aorta. This inner lining would have been the true lumen, the initial aortic opening, the tunica intima. As the layers separated, you then begin to create this false lumen, this balloon around the outside of the true lumen. And as that separates, you allow more blood to collect inside this weakened outer balloon, which can either, one, perforate and rupture, or two, can cause so much pressure around the true lumen that you're now restricting blood flow to the rest of the body through that initial lumen hole. Okay, when you hear people talking about tearing pain, it is exactly what's happening. These two layers are tearing and separating off. And so they couldn't explain it any more obviously. Hopefully, you are catching that and paying close attention to it. Here's several different ways, or 2 different ways, that we categorize aortic aneurysms. There's the Stanford method and the DeBakey. A DeBakey shows a type 1 and 2 show the ballooning or the separating occurring in a type 1 in both the ascending and the descending aorta. A DeBakey type 2 is strictly the ascending aorta, and a DeBakey type 3 is in the descending only portion of the aorta. A Stanford categorizes the letter A aneurysm as occurring anywhere with the ascending, any portion of the ascending aorta. So I remember A for ascending aorta involvement, and B is beyond, only beyond the aortic curve. So it's a little bit more specific with the DeBakey, and the DeBakey gets worse as you go from more numbers to the first number. It's like the nuclear clock. We're in what do you call that? What do they call that? Whoops, sorry. DEFCON. It's like you're in DEFCON 1. That's worse than DEFCON 5. Anywho, let's get back to this. So, okay, those are what it is specifically. Now, what are the risk factors for aortic aneurysm? Well, there are several different genetic disorders that what would you say? Oh, geez Louise. There are several different genetic factors that predispose you to aortic aneurysm. So Marfan syndrome, these are all connective tissue disorders for the most part. Connective tissues like Marfan's, Ehlers-Danlos, which was the case of our other patient, Turner syndrome, Louise-Dietz, and any ones that really do cause kind of weakened or elastic connective tissue. I have a picture of Abraham Lincoln here. He was considered more than likely had Marfan's because it's very, very common in very tall, thin, lanky people, large joints. You see kind of prominent foreheads. Again, with these patients, a lot of them can be that same kind of long, lanky, tall basketball player kind of injuries. They're also, coincidentally, and for the same reasons, um, they're also subject to collapsed lungs, pneumothoraces, because of the same issue. They have very flexible connective tissue, in this case, the pleura that covers the lungs, also likewise is able to flex and bulge and pop. And so, again, if you are predisposed to one genetic connective tissue disorder, you're going to be exposed, or you're going to be, a candidate for all of them. We'll get down into Louise-Dietz is an interesting one. It's an enlarged aorta. You have a bifurcated uvula in some cases. Patients might have a cleft palate. There are some premature bone fusions that can occur. So if you know this patient doesn't know maybe they have Louise-Dietz, but they complain of something like skeletal problems or premature bone fusion as a child, or issues with healing and scarring and a cleft palate, I would also be cautious that this could be also an aneurysm patient. However, even if you don't have these genetic prefactors, you could also have dietary lifestyle issues that are causing these problems, like atherosclerosis and hypertension. Poor diets can lead to this. Alcohol abuse, drug abuse can lead to this. So make sure you're keeping your coffee intake at a minimum, ideally, and try and avoid crack if you can. Right? Please stay away from crack on a regular basis, and that goes for coke and speed and everything else. And probably in today's society, speed seems to be the drug of choice among the proletariat, and even among the aristocracy too. You'd be surprised. So if they are into speed, crack, cocaine, they're also, if not genetically predisposed, then lifestyle wise, they're predisposed. Also, infections, childhood or even adult infections, fungal, viral, bacterial infections, like strep even, affects the heart and eventually the aorta. So endocarditis, syphilis, strep, even if treated, they are now at a higher risk for having some kind of connective tissue aortic aneurysm problem. There's also aortic coarctation, or a narrowing of the aorta. If just anatomically your aorta is more narrow, you're going to, because of that, you're going to have a higher pressure in that area, and that higher pressure can blow out essentially more easily at some point, especially if you're mixing that with drugs and you have some predispositions genetically to it. So let's say we're looking for those things and our patient does have those. We know that the patient is dealing with Ehlers-Danlos, has myalgia, did have some stimulants, as a matter of fact. All right, so are we really concerned with this patient? I would be. So let's try and figure out, are we seeing present signs and symptoms? And if you suspect aortic aneurysm, one of the main things we go after for any aneurysm patient is checking pulses bilaterally. This is why I teach students to check your pulses on every patient when you're doing your physicals. Get them bilaterally. Get in the habit of checking bilateral wrist pulses, radial pulses on all your patients. and see if you're feeling, and you can feel equal strengths on both sides. If you have a patient like this, not only would I recommend checking bilateral pulses, get bilateral blood pressures, check both sides if at all possible. I mean, if they have a stent on one side, maybe that's going to limit your accuracy and your ability to do blood pressure there. However, if there's nothing limiting you there, right, like a stent or like an amputation, which again would be rare, then check them on both sides. Get bilateral. This get with right bilateral blood pressures, and this you're only going to think to do if you're already suspecting aneurysm. However, if you haven't gotten to that step yet, well, here are some things that might push you to aneurysm versus heart attack or pulmonary embolism. The chest pain that begins is sudden. It happens suddenly, acutely, and it goes from 0 to 10 to 10 out of 10. That is a really big indicator of an aneurysm, typically with heart attack, with ischemia, or even with pulmonary embolism. It starts at a low number and then begins to increase over maybe a few minutes or so. However, this is not the case with aneurysm. And because this is an actual physical issue, it's the tissue is tearing and moving inside the skeletal system. See this? Here's your aorta. Here's the trachea branching just under the aorta. Here's the esophagus pressing up against the aorta. And then behind that, even, is the spine. So, because of that, breathing is going to change the pressure of that aorta. Movement is going to put pressure on the aorta. Coughing is going to actually affect the pressure in there, and that will cause pain to increase as they're moving and breathing and you're palpating. Even more so if you're giving drugs that are vasodilators, uh, like morphine and nitroglycerin. Now, in some counties, there are places where you are capable of giving nitro and even morphine, from what I've been told. I've not worked in any of those counties. And in fact, if you have begun down a cardiac protocol and you've given your nitro and you notice the pain actually increases rather than staying the same or decreasing, that should be another red flag warning for you to think not cardiac, cardiovascular. Okay, and then you have that radiation sometimes where we get where bleeds are occurring, or referred pain to the low mid back, high back, shoulders. Very uncommon with cardiac patients, especially like low back, and a severe 10 out of 10, or even in the cases that I've had, a pulmonary, a thoracic aortic aneurysm patient, 20 out of 10. They could not speak. It hurt so badly. And it's constant, it's instantaneous, it's severe, it's unrelenting. Here are some unusual signs and symptoms along with it: sore throat, okay, hoarse voice, difficulty swallowing, cough, shortness of breath. And that is all due to the fact that the aorta is brushing up so closely to those other anatomical structures for digestion, respiration, etc. So any of that also stimulation of surrounding tissue is causing an increase in pain, or a sore throat, or hoarse voice, difficulty swallowing. If this were unusually large and ballooning out, well, it's going to be pressing on the esophagus, and it's not going to be allowing food to physically get past that ballooning through that false lumen. So pay close attention to those odd things like grunting, or clearing their throat, or, swallowing and saying like, I can't, feels like I can't swallow, that kind of thing. These hopefully are getting you to think, hey, together with the blood pressure being so low, the pulse being so high, their respirations seemingly painful and elevated, their skin signs showing signs of shock, but their heart rate looking good. In fact, you put them on the EKG and is a nice steady rhythm, no problem with it. It looks perfectly healthy, perfectly clear. You may even, hopefully, you begin to suspect thoracic aneurysm prior to, you've given your nitro and the pain's increased. Well, let's check a 12 lead or something like that, and you don't see any you don't see any um, ectopy, and you don't see any evidence of ST elevation. Something's going on still, right? So maybe you show up, and in our county, we want to get a 12 lead before we really do anything else, ideally before even pharmacology, because we know that, nitro and eventually morphine, but nitroglycerin and oxygen are going to quell the ischemia, and it's going to then mask or remedy and then mask any potential ectopy that we might see from the 12 lead. So if you've gotten your 12 lead, and again, they're complaining a 10 out of 10 chest pain, and it looks like a perfectly healthy heart, and then you go, that's weird, and you give the nitro and the pain gets worse, and you're looking at that coupled with the low blood pressure and the rapid pulse and the skin sign, there's a life-threatening condition that is certainly going on with this patient. They're becoming unstable, and it almost definitely has nothing to do with the heart tissue itself. Would you agree with that? Could you ascertain that? Could you make that leap in logic based on those bits of information, based on the blood pressure, the pulse, the the change in pain when nitro is given, the 12 lead that is showing no issues? Would you then be able to say, well, something is causing this? This isn't fake, and it's unstable, and I don't see any heart problem. In fact, when I started treating for heart problem, the pain increased. I hope that is enough for you to start realizing this is something other than the heart, and this is something that I cannot treat as a paramedic on this call. The number one thing we can do for these patients truly is rapid recognition and transport. They absolutely have to get to the hospital, where more treatment and surgery, more than likely, and immediate surgery will be needed. Okay, here are some things to keep in mind as you get this patient stabilized relatively and transported to the hospital, packaged up. You need to be extremely gentle with these patients. You have to move them very little to get them onto the gurney. Probably the best thing for you to do is sit pick or find some method of getting them from their position onto the gurney without any self-ambulation and without any rough movement on the crew's part. Any of that movement and jostling and repositioning can begin to separate out the layers of the aorta and obviously also cause rupture. And if any of those things happen, your patient's chance of survival have just dropped to nearly nil. So high flow oxygen, gentle movement to the gurney. Maybe if you didn't get one immediately, get another 12 lead to rule out any obvious MI issues. And then if there's some cases where you can potentially give pharmacology for that in your county, make sure that you're aware of that and treat that appropriately. I just want to add this, which I always hesitate to add, but I do feel it's absolutely important. When I had a thoracic aortic aneurysm patient, this patient was presenting with 10 out of 10 chest pain, low pulse, was not speaking to me because of the pain. We wheeled the gurney over. She stood up and sat down, and as she put her feet up, she went, oh, and sat down and said, "My pain's killing me." And by the time we got her to the ambulance, she had stopped breathing. She was no longer conscious. What had happened was she had probably stood up, and whatever was there either separated more or ruptured. By the time we got her into the ambulance, she was no longer conscious. She was not breathing, and she did not have a pulse. We continued CPR on the way to the hospital while looking at a EKG monitor that showed that the patient had a regular pulse, albeit it was a rapid tachycardia. It was still considered, it was sinus, but we were in pulseless electrical activity. And I knew we weren't getting her back. Nevertheless, we continued CPR. We continued giving cardiac meds all the way to the hospital. When we got there, the hospital crew went, "Oh, yeah, this is obviously an aneurysm." Okay. So that patient died on our watch, and we didn't fix it. I didn't fix it. I have never forgotten that call. I've never forgotten that patient. And that's why I give this lecture to you. I want you to be aware of that and not make that mistake where I wasn't even considering something as small and jostling as the patient standing up on her own and sitting down enough to kill her. And that's very definitely or very possibly what happened. And so that's my problem. There's nothing I could have done to fix it in the field other than maybe completely picking this patient up and moving her without a single movement. And even then it's unclear if it would work or not. But I've never forgotten that. And afterwards, I've had an aneurysm patient, and I've never made that mistake again. I've never made that overlook ever again. And I hope that by me giving you this lecture, you don't ever either. I hope I save you the regret and the loss of a patient. Let's make sure that her death stops any others. Thanks very much for listening. And if you have any further questions, feel free to email me. And if you enjoy this, please pass it on to a friend, and stay tuned for more of the Above and Beyond series lectures, where we'll discuss more of these kind of life-threatening emergencies that don't get the attention and the heart that they deserve. Take care.